I'd like to welcome everyone to our webinar today on exploring personalized therapy for first-line treatment of advanced non-small cell lung cancer. I'm very happy to have Dr. Suresh Ramalingam, who is the Director of Thoracic Oncology and an Associate Professor at Emory University in Atlanta, Georgia, joining us today. Dr. Ramalingam and I are now going back several years, and we've been good friends and colleagues for the time that we've really been watching this topic change over the last several years, and it's really all been for the better. Dr. Ramalingam is not only leading a lot of very important research at his own institution, but he is also now the vice chair of the Eastern Cooperative Oncology Group's Lung Cancer Committee. And with that, it's a big role that is involved with a lot of pivotal research that is going to be changing standards of care in the next few years. I'll also add that the program is made possible with the support of an educational grant from Eli Lilly Oncology. And Eli Lilly did not have any role in the development of the content here. And with that, I'm very happy to turn it over to Dr. Ramalingam, who will lead us through this complex and changing topic.
Thank you, Jack, and good evening to everybody. It's an honor and pleasure to be able to talk to you all today. At the outset, I would like to disclose my conflicts of interest. These are what you see on the screen, institutions and companies from which I have received honorarium for serving as a consultant. I am going to be talking on data from established literature, and I believe that none of these affect the content of this program. Initially, what I want to do is set the stage up by giving you some basic information about non-small cell lung cancer, and then moving on to talk about treatment options as they evolved over the past few years, and hopefully give you a flavor for how things are going to be in the very near future. So, as you all know, lung cancer is now the leading cause of cancer-related deaths, not only in this country, but worldwide. More than 1 million patients die from lung cancer each year globally. There are two broad types of lung cancer. We classically categorize them as being non-small cell lung cancer, which accounts for about 85% of all lung cancers, or small cell lung cancer, which accounts for approximately 15% of all lung cancers. Interestingly, the incidence of small cell lung cancer in the past 20-30 years has decreased somewhat compared to an increase in the incidence of non-small cell lung cancer. The other fact that is often not given adequate attention is that even in women, lung cancer is the leading cause of cancer-related deaths. It's not breast cancer, it's not ovarian cancer. Lung cancer by far exceeds the mortality related to cancer even in women. Now, if you look at what has happened in the past 50 years or so, is that the incidence of lung cancer, which in the 1930s started to increase significantly, appears to be plateauing. In the past 15-20 years, in men, we have started seeing encouraging downtrend in deaths related to lung cancer, but in women, we're probably just hitting the plateau. And that relates to the change in smoking patterns over the past 30-40 years. Let's focus on non-small cell lung cancer for the rest of the discussion. 80 to 90% of the patients with non-small cell lung cancer have a history of smoking cigarettes, and in about 10 to 15% of the patients, lung cancer occurs even though they have never smoked. We think that people who have never smoked cigarettes get lung cancer because they may have been exposed to secondhand smoke, or they may have been exposed to some of the other less common causes of lung cancer, such as exposure to radon and asbestos. Now, when we look at non-small cell lung cancer, we divide it into a number of subtypes based on histology, or how it looks under the microscope to the pathologist. Adenocarcinoma is the most common subtype in the United States. Squamous cell carcinoma used to be the more common variety about 20-30 years ago, but that has gone and taken the second position now. The other subtypes are large cell carcinoma and bronchoalveolar carcinoma, both of which account for probably around 3 to 5% of all lung cancers each. In about 20 to 30% of the patients, when the patients get the biopsy, despite best efforts, the pathologist cannot specifically say what subtype the cancer is. And that's often because the cancer cells have multiplied and divided so many times that they no longer resemble what the cell type where things started off as. So the pathologist calls it non-small cell lung cancer, not otherwise specified, or just poorly differentiated cancer. And we are not sure what original cell type it started from in these patients. One of the major challenges with non-small cell lung cancer is that it is diagnosed at a relatively advanced stage in a majority of the patients. In the next slide, I show a picture where only about 10 to 20% of the patients have stage 1 disease, and about 50% of the patients have stage 3 or 4 disease by the time the cancer is diagnosed. And this is an area where we really need to make improvements because advanced stage disease is not considered curable, whereas early stage disease is. So if we had a good screening tool, one could potentially diagnose lung cancer earlier, thereby catching it at a more curable stage rather than at a treatable stage. Stage of the disease is the most important determining factor when one talks about treatments. We divide the stages as stage 1, 2, 3, or 4, and the stage is an estimation of the extent of the cancer. If the cancer is just localized to where it started, it's typically called stage 1 disease, and even within stage 1, we divide them into various categories based on the size of the tumor. The larger it grows, the stage becomes more advanced. What also changes stage is if the cancer has gone on to involve the lymph nodes or distant organs, which we call metastatic involvement. So if somebody has stage 1 to 3 where the cancer has not spread outside the chest or outside the vicinity of where it all started, surgery is still possible for these patients. However, for patients with stage 4 disease, surgery is not an option because the cancer has already metastasized, and taking out one part of the tumor or one area of the tumor is not going to help these patients. For stage 3 patients, sometimes the cancer is sitting directly on a major structure such as the aorta, which is the major blood vessel, or say a vertebral body, which is the spine. And for those patients, surgery is not possible. Therefore, we give chemotherapy with radiation as a standard treatment approach. And even chemotherapy with radiation is associated with cures in a good number of patients. What do we call advanced stage disease? Well, we talked about metastatic involvement, which is spread of the cancer from the lungs where it started to any other part of the body. It could be to the other lung, it could be to the brain, it could be to the bones, adrenal glands. So all of these are referred to as extrathoracic sites. One also categorizes patients who have fluid buildup around the heart or the lung as being indicative of advanced stage disease. Not all fluid constitutes advanced stage disease because one can have fluid buildup without it being directly related to cancer. So in patients who have fluid buildup around the heart or the lungs, we remove some of the fluid, test it to see if cancer cells are present, and if they are present, then that categorizes them as advanced stage lung cancer. Now, how do we treat advanced stage non-small cell lung cancer? We have a variety of treatment options available. We have standard chemotherapy options, which, as you will see, have increased in number of agents available in the past few years. We have also a number of targeted therapeutic agents, such as Avastin, Erbitux, Tarceva, and Iressa in a limited basis. So these are what we call targeted agents, and we will talk about them in the next few minutes. In the 1980s, the platinum compounds, which is cisplatin and carboplatin, became the mainstay of treatment for lung cancer. And several studies compared platinum agents with supportive care and showed that giving chemotherapy in advanced stage disease is associated with a survival benefit. In the 90s, folks built on platinum-based therapy. They added a new chemotherapy drug such as Taxol, Taxotere, or gemcitabine to carboplatin or cisplatin and showed that two drug combinations are better than giving platinum alone. Studies also showed that giving two drugs are better than giving the non-platinum drug alone as well. The one caveat is that not every patient with lung cancer will be able to tolerate the two drug combinations. Patients will have to have a relatively good functional status, which means they should be able to perform their regular functional activities to a good degree, which is an indicator of how well they are able to tolerate the treatments. In the year 2000, a landmark study was reported, and this we refer to as the ECOG 1594 study. And this study was done to compare 4 different two-drug combination regimens to see if any one of them would emerge superior. And what the study showed was that all 4 regimens were associated with very similar effectiveness. The survival duration was similar. The response rate, or the percentage of patients where the tumor undergoes considerable degree of shrinkage, was the same for the 4 regimens. The only differences that were seen were that each regimen had its own side effects profile. So the study concluded that with the 2-drug combinations, we have hit a plateau, and mixing and matching chemotherapy regimens was unlikely to lead to significant improvements in overall outcome. So when that study was published, treatments for patients were chosen based on a number of factors. So when there was a patient sitting in front of a physician, since multiple treatment options were available, how would you choose the right regimen? Well, that depended on the patient's functional status, the pre-existing medical conditions that the patient had, such as heart disease, kidney disease, liver disease. One other important factor was the side effect profile of the medicine and how it might alter the functioning and the quality of life of a given patient. The ease of the schedule was also important because some drugs were given more frequently, some were given less frequently. So depending on how far the patient had to travel to get the medicine, that was also a factor. So this is how treatments were chosen about 7-8 years ago for treating non-small cell lung cancer. These were basically patient-specific factors, patient convenience, cost to a certain extent, all factored into selection of therapy. So what I'm going to talk to you in the next few minutes is to show you how treatment selection is changing from these factors to more molecularly based, histology-based, individual patient-specific options. When we talk about histology-based, the drug that is the first to be approved in lung cancer for specific histology, the chemotherapeutic drug, is Alimta. And Alimta is a drug that works by blocking some of the key enzymes that are necessary for the dividing cells. There was a large study conducted which combined cisplatin with Alimta and compared it to cisplatin and gemcitabine. And this trial had more than 1,700 patients. This is by far the largest trial conducted in advanced stage non-small cell lung cancer until this date. And the trial showed that the cisplatin-Alimta regimen was similar to cisplatin-gemcitabine regimen in effectiveness, but it had a better side effect profile. In other words, patients had less significant side effects when they got the cisplatin-Alimta regimen. What was very interesting in this trial was the fact that in patients who had adenocarcinoma or who belonged to the broader non-squamous category, there was superiority for survival for patients treated with cis-Alimta. In other words, patients who had non-squamous histology had better outcomes when they were treated with cisplatin-Alimta compared to those who were treated with cisplatin-gemcitabine. So based on this, the US FDA has approved the cisplatin-Alimta regimen for non-squamous histology. Alimta has also been approved in other settings in non-small cell lung cancer. It is approved in quote-unquote second-line therapy, which is the treatment that's given for patients who get some form of therapy first and then have progression of disease. Alimta is also now approved in maintenance therapy, which is after patients have achieved maximal benefit with combination chemotherapy, a drug that's given to sort of keep the disease under check is referred to as maintenance treatment. And Alimta is actually the first drug in non-small cell lung cancer to have a unique maintenance therapy indication. It is not to be used for squamous histology or in patients with severe renal problems. So Alimta is now specifically preferred for patients with non-squamous histology, either in the first-line setting, second-line setting, or the maintenance setting. Alimta is an example of a newer chemotherapy drug that has led to improved outcomes in non-small cell lung cancer. The other major area of progress has been with targeted agents, and this is where our ability to individualize treatments to patients based on specific tumor factors is emerging. What is individualizing therapy? Well, it is basically not using the same treatment for all patients. In other words, we don't use the one-size-fits-all approach for advanced stage disease. We look for specific patient characteristics, the patient sitting in front of you, what is his or her tumor like, and what markers or proteins are expressed in the tumor that we can use to identify whether he or she will respond to specific treatment option. Now, we are not entirely where we want to be, but we are certainly farther along in individualizing therapy than we were a few years ago. And that's what I'll show you in the next few minutes. When the plateau was reached with chemotherapy, when combining two drugs, all two drugs appear to be more or less the same, the research community started combining a targeted agent with standard chemotherapy in the earlier part of this decade. And a number of clinical trials were done, most of which showed really no benefit to combining a targeted drug with chemotherapy. And that's because we did not understand very well the mechanisms that underlie the combinations. What happens if you put these two drugs with the targeted drug in the test tube was not the same as what happened when they were given to patients. And it basically taught us that a more sophisticated understanding of interactions between various drugs is necessary. The first time success was achieved when combination of chemotherapy and targeted drugs were given was with Avastin. Now, what is Avastin? It is an antibody that basically works by cutting off blood supply to tumors. Why is blood supply important? When a single cell that develops an abnormality starts developing cancerous characteristics and starts multiplying, after it reaches a very critical size of 2 to 3 millimeters, that's almost the size of a pinhead, it needs new blood supply to grow. It will simply not grow if there was no blood supply to it at the size of 2 to 3 millimeters. And in order to form new blood vessels, the cancer cells start secreting various chemicals. And VEGF, or vascular endothelial growth factor, is a very important protein secreted by the cancer cells that leads to new blood vessel formation. So Avastin and a number of other drugs that are now on clinical testing block the effects of VEGF and prevent new blood vessel formation. There's also some suggestion that they may cause normalization of the tumor's own blood vessels and thereby be able to deliver chemotherapy better to the tumor. So when Avastin was combined with chemotherapy in the ECOG trial, there was superior survival for patients who got that combination compared to those who got chemotherapy alone. For the first time, we reached greater than 50% one-year survival in non-small cell lung cancer, which means more than 50% of the patients treated with the combination of Avastin and chemotherapy were alive beyond 1 year, and almost 25% were alive at the 2-year time point, which denotes a significant improvement in overall outcomes, though it doesn't go close to our ultimate goal of cure for this disease. When one talks about Avastin, it is important to understand that it is not a drug that everybody can get. It does have a higher risk of bleeding, and when given in combination with chemotherapy, it can also cause suppression of blood counts for a greater degree. Therefore, you really need to be careful about who is treated with Avastin. Patients with squamous cell histology should not be treated with Avastin because there appears to be a higher risk of bleeding in this tumor type. Patients who had blood clots in their arteries within the year before they were diagnosed with lung cancer should not be treated with Avastin because there may be higher risk of similar events happening again. We also avoid giving Avastin to patients whose blood pressure is uncontrolled because Avastin and drugs that belong to this class actually can increase the blood pressure, and often it may necessitate the use of blood pressure lowering medications. There is also evidence that the older a patient is, particularly when you talk about late 70s and 80s, there may be a higher risk of side effects with the use of Avastin in combination with chemotherapy. Already, as we saw for Alimta, where we use histology as a factor for treatment selection, for Avastin, histology is a factor, and we also use certain other characteristics to select therapy for a given patient. There are also a number of drugs that block the VEGF pathway that are now in advanced stages of clinical testing, and it is hoped that one or more of these agents will add to our treatment options for patients with non-small cell lung cancer if they prove to be beneficial. I'll switch gears and talk about the EGFR pathway, which is probably the most exciting area in non-small cell lung cancer in my mind. The EGFR stands for epidermal growth factor receptor. This is a pathway that is very critical for the cancer cells. It is expressed in cancer cells in almost 40 to 80% of patients. But what is more important is that it can be mutated in about 10 to 15% of the patients. And why is that important? Let me show you in a cartoon that the EGFR is a receptor that's present in cancer cells. And this receptor is basically a switch. It is turned on by a number of factors, but once it's turned on, it basically drives the cancer cell. It makes the cancer grow new blood vessels. It makes the cancer spread to other organs in the body. It prevents the cancer cells from dying voluntarily, which is one of the main mechanisms why cells can divide and go on for a long time. So this switch turning on is a critical event. The research efforts focused on how can we turn on the switch. And there are now a number of drugs that can do that. Tarceva is one. It's a pill that's administered orally that blocks the receptor on its internal surface. IIIA is a drug that is available on a restricted basis that also does more or less the same thing. We also have antibodies such as Erbitux, which can block the receptor on its outer surface. So there are a number of ways by which one could block these receptors. And what was seen initially in a large trial, patients given Tarceva lived longer than patients given placebo. This was for a group of patients with advanced stage non-small cell lung cancer in a trial conducted in Canada and some of the other parts of the world. And this was the first trial where a targeted drug by itself, not with chemotherapy, by itself, led to favorable outcomes for patients with non-small cell lung cancer. Based on this, Tarceva is now approved by the FDA for second and third line treatment of non-small cell lung cancer. When Tarceva was initially being studied, and even for IIIA, it became very clear very earlier on that there were some patients who derived really great degree of benefit, and then for the rest, it was a modest amount of benefit. And when I say great degree of benefit, these were patients who were almost disabled to the point where they couldn't function, they required oxygen at home, and when they got this drug, within a week or two, they found dramatic improvements in their symptoms, their ability to perform daily activities, and these patients went on to live, in some instances, even beyond 5 years. So the interesting part was, how can we identify who these patients are? And in these trials, it was often women who had these kind of responses. It was patients with adenocarcinoma, and most importantly, patients who had never smoked cigarettes. And another important factor was patients who had Asian ethnicity appear to do very well with these drugs. So the question became, why do these patients that we talked about, women, adenocarcinoma, never smokers, Asian patients, why do they do very well? And the answer to that came in the year 2004 when there were two large papers published, one in the New England Journal of Medicine and the other in Science, which showed that these patients had a mutation in the receptor. So essentially what this mutation does, it's a super switch. We talked about EGFR being a switch. When the EGFR has a mutation, it actually becomes an even more dominant pathway. And for these patients, their cancer cells thrive just based on the super switch being turned on. And when you turn off the switch with a drug like Tarceva or IIIA, their cancer is completely starved of the signals it needs and therefore dies very quickly. So this is really what changed the way we use EGFR inhibitors in the treatment of lung cancer. So who are the patients who have EGFR mutation? Now let's go back to what we just talked about. Women, about 20% of the women appear to have the EGFR mutation in the U.S. These are Caucasian patients. Asian patients, the incidence of EGFR mutation is even higher at about 40%. Patients who have never smoked cigarettes, which is defined as less than 100 cigarettes in their entire lifetime, appear to have EGFR mutations at a frequency of about 40%. And if you look at adenocarcinoma histology, about 20% of them have EGFR mutation. So the question is it good to have an EGFR mutation? The answer is yes. The reason erlotinib or gefitinib, which Tarceva or IIIA, the trade names, work very well in patients with EGFR mutations. In these patients, the response rate, which is the percentage of patients where the tumor undergoes considerable degree of shrinkage, is in the excess of 60 to 80%. And these drugs keep the tumor in control sometimes for even years together. And in fact, there is increasing evidence that even chemotherapy works better in patients whose tumors have an EGFR mutation. So EGFR mutated tumors, which is about 10 to 15% of all lung cancers in the U.S., are now being acknowledged as a distinct entity of non-small cell lung cancer. So who should be tested for EGFR mutation? There is a commercial test that is available. It does add an additional cost to all the other expenses involved in diagnosing and staging lung cancer. And more importantly, from a logistical standpoint, it could take an additional 2 to 4 weeks to get the results of this test, as the situation may be. It is not practical to get the test in every patient. Sometimes there is not enough tumor tissue to test. These tests are done in the tumor tissue or the biopsy specimen which the patient had for the diagnosis of lung cancer. So in our institution at Emory, we increasingly feel that patients who have never smoked cigarettes and those with adenocarcinoma should definitely be tested for this mutation. Some institutions offer it to everybody. Some institutions offer it to even a restricted group. But I see that this is going to only take off more in that a higher proportion of patients are going to be tested for EGFR mutation. Now, for the time being, it doesn't look like having that information changes the big picture in a large way. And what I mean by that, I'll tell you in the next couple of slides. Once the EGFR mutation story evolved, there was a large randomized trial conducted in Asia, which compared the use of IRESA to the standard chemotherapy regimen of carboplatin and Taxol. And this trial was for first-line treatment of non-small cell lung cancer. And they only chose those patients who they thought might have the mutation. So they picked patients with adenocarcinoma, patients who were either light smokers, which is less than 10 pack years, or never smokers, and treated them with either IRESA or the chemotherapy combination. More than 1,000 patients were enrolled to this trial, and what it showed was very interesting. The duration for which the cancer was free from progressing was actually higher for patients treated with IRESA compared to chemotherapy. So there were about 600 patients who got IRESA, 600 patients who got chemo on this trial. It was randomized. And the 1-year time point at which patients had not had progression of disease was 25% for patients treated with IRESA compared to only 7% with chemotherapy, which means in 93% of the patients who got chemotherapy, their cancer had gotten worse, whereas with IRESA, it was only 75%. So 25% were controlled with IRESA. Even more striking, they went back and collected the tumor tissues from about 400 patients and tested them for mutations, and then redid the analysis, and the findings were even more striking. If the patient's tumor had an EGFR mutation, IRESA was superior to chemotherapy. On the other hand, if the tumor did not have the mutation, chemotherapy was superior to IRESA. So what does this mean? Well, if you have a patient that already is known to have an EGFR mutation, you can give them Tarceva or IRESA. If you have a patient for whom we do not know whether they have the mutation or not, if we give them IRESA or Tarceva, we could actually be harming those patients by giving this agent instead of chemotherapy if they don't have the mutation. So what this all boils down to now is that if a physician is considering giving Tarceva for a patient in the first-line setting, it is imperative that they make sure that the patient's tumor has EGFR mutation. If you don't have the information, it's better to get chemotherapy. The reason is, if you give Tarceva either in the first or the second-line setting, the benefit is still maintained. So it's better to play it safe by giving chemotherapy first, and when the tumor progresses, you give Tarceva. Thereby, the patient anyway does better and gets the benefit of both of these important groups of drugs. The field has even evolved further in that in Japan, they conducted a clinical trial where they only selected patients with the mutation and randomized them to IRESA or standard chemotherapy. And in this trial, the survival and progression-free survival curves were very remarkable. The outcomes were almost twofold better for patients treated with IRESA compared to chemotherapy. So this again confirms the fact that if a tumor has the mutation, then giving EGFR inhibitors is better than chemotherapy in the first-line setting. Now, there are also other mutations in the cancer cell that may influence response to EGFR inhibitors. One such event is called KRAS mutation, and it is actually a wiring circuit that is turned on by the EGFR switch. So one can visualize KRAS as being the machinery that is activated by the switch, or part of the machinery that is activated when the switch is turned on. So it's part of the circuit. And in patients where there is the KRAS mutation, the use of a drug that blocks the EGFR does not seem to shut off the switch. So in other words, you turn off the switch, but the light is still on because the KRAS keeps the light on, and you are not able to break the circuit. In a study that was conducted in New York, they showed that among a group of patients who were treated with Tarceva, the best responders were those who had the EGFR mutation, and hardly any patient with KRAS mutation experienced a major response to treatment with Tarceva. Now, this is an evolving situation where we don't have all the answers yet, but it looks like patients with KRAS mutation, even if they benefit with Tarceva, the degree of benefit is not quite as large. What is also becoming clear is for a patient who is treated with Tarceva because he or she has an EGFR mutation, these drugs don't work forever. In some patients as early as 8 to 9 months, in some patients after a few years, these tumors develop additional mutations and become resistant to Tarceva and Iressa. So now we have new drugs that are coming into the research arena that will address the so-called secondary mutations. In other words, patient had an EGFR mutation, got treated with Tarceva. After a while, the tumor became resistant by developing a secondary mutation. So these drugs are now in clinical trials. We also have antibodies against the EGFR like Erbitux and Vectibix that are being used in a large clinical trial that was reported at ASCO a couple of years ago. It was shown that adding Erbitux to chemotherapy was associated with a modest improvement in survival compared to chemotherapy alone for patients with non-small cell lung cancer. The interesting thing here was that the survival benefit was seen in both squamous cell cancer and in adenocarcinoma patients. Erbitux is not yet approved by the FDA. It is not currently approved, but it is available for a number of other cancers. And the overall feeling is that for squamous patients where we don't have a targeted drug, Erbitux may be an option. What is more exciting about Erbitux are data that suggest that in combination with radiation, Erbitux appears to be very active. So there is a large clinical trial that is currently ongoing, not for advanced stage, but what we call locally advanced stage disease patients. Giving Erbitux in combination with chemotherapy and radiation is being compared to chemotherapy and radiation alone. In patients with head and neck cancer, it is already approved that Erbitux can be used with radiation because there is considerable positive interaction between these two drugs. So if what was true in head and neck cancer holds good in lung cancer, then we may soon have a drug that can be given with chemotherapy and radiation that is associated with better outcomes. Now, one of the last things I want to touch about is a new molecular factor that is becoming very exciting in lung cancer. We talked about EGFR mutations as being present in 10 to 15% of lung cancer patients. Now, what we are learning is that a new molecular abnormality, it's referred to as EML4-ALK translocation, which is another dominant switch for lung cancers. Now, this switch is only seen in about 4 to 5% of non-small cell lung cancer patients. And this is likely to be seen in patients who are younger in age, more commonly men than women, adenocarcinoma, and they particularly have certain features called signet cell features, which the pathologist can look at the tumor and say. And these patients also tend to be those who have never smoked cigarettes. And as I said, this is about 3 to 4% of all cases of non-small cell lung cancer where we see this EML4/ALK translocation. Now, why is this relevant? Well, there is a drug that is being tested by Pfizer Pharmaceuticals that appears to work very well for these patients. This drug just recently got a name. It's called crizotinib, CRIZOTINIB. This is an orally administered drug. And in almost 2/3 of the patient with this molecular abnormality that got this drug, it has demonstrated major responses. Now, it is only available as part of a clinical trial. It is not available in routine care. But if there is a patient who has advanced stage disease, has never smoked, and does not have an EGFR mutation, I think it is relevant to check for this EML4ALK translocation, and if it is present, be enrolled in a clinical trial that is available in many major centers across the country now to test whether this particular compound works for these patients. And hopefully these trials will then bring this compound to the market. There are also, very early in the development, some other compounds that can block this specific molecular switch called EML4ALK. So I would say stay tuned to this. This is a very exciting and emerging area of lung cancer. Though it only affects 3 to 4% of the patients, we may have an effective option for these. So if you add up mathematically the patients who would have EGFR mutation and those who have EML4, you're already talking about 20% of all lung cancers, which is for 1 in 5 patients with lung cancer, we will now be able to give specific treatment based on their tumor's molecular status. And I think this is really where the field is heading. What we want is a specific molecular abnormality or marker-driven treatment for all 100% of patients with non-small cell lung cancer. But the current state of knowledge at this point, which is evolving rapidly, is already 20% better than what it was a few years ago. So I'm going to finish up finally talking about clinical trials. I know this group is well aware of clinical trials. Clinical trials are the only way new treatment advances are brought to routine practice. At present, about 3 to 4% of adults, only 3 to 4% of adults with cancer are treated on clinical trials. Now, no matter how exciting a drug looks in the laboratory, until it's tested in humans, it can never reach the market. So if we double the number of patients enrolled on clinical trials from, say, 3 to 4% to 8 to 10%, we can actually cut the time to discovery of new medicines by half. Right now, it takes about 10 to 15 years to bring a new drug from the bench, from the time it's identified, until it can be brought into the clinic. And if we can cut the time to half by adding more patients and treating more patients on clinical trials, we would already be making major progress. Why do patients not go on trials? There are a number of common myths. There is this perception that being treated on a clinical trial means one is being a guinea pig, or perhaps the patient may not get standard options such as in placebo-controlled trials. What I want to say is the clinical trials always involve standard of care. By participating in a clinical trial, one would not be denied standard of care treatment. Clinical trials typically build over standard of care, not under it. And also, in most instances, the insurances, at least in phase 2 and 3 trials, cover the standard of care components to make sure that the patients do not have any additional costs. And this is something that can be easily found out even before one signs up to see if there were any coverage issues. So I would encourage everyone who has a trial available to consider participating in a clinical trial. Finally, what role can all of us play for improving lung cancer outcomes? Well, I think it's important for us to continue to be champions for lung cancer research. Research is the only way we're going to make progress. We need to be advocates for smoking cessation. We need to, more importantly, educate children against taking up cigarette smoking. And in my view, if we can do something that will have a long-lasting impact on reducing the burden related to lung cancer, that is avoiding a teenager from taking up smoking. And we also need to support patients, family, and friends of those who have lung cancer, as many of you have been doing. So in closing, I hope I have been able to show you that treatment of lung cancer, non-small cell lung cancer in particular, is moving from an empirical approach to a patient-specific individualized approach. The landscape is changing rapidly, and we hope that with more new drugs that are being tested and more biomarkers and molecular markers that are being tested, we will be able to match up more patients to specific drugs. Thereby, they can have longer and lasting favorable results as opposed to transient and shorter term of benefits. So I want to thank all of you for listening to me. I also want to acknowledge Dr. West. I have known him for several years, And I cannot think of too many people who have more passion than Jack for advancing cancer education and improving outcomes for lung cancer. I also want to thank the Internet, without which meetings such as this would not be possible. And I would be happy to answer any questions. Thank you all, and I hope you found this useful.
Well, I would like to express my sincere thanks to Dr. Ramalingam for a great presentation, and have a great night.
Thank you. Bye.